All right, so that's going to be disappointing. All right, so what we're going to do is we're going to discuss today some principles of pharmacology, right? Not too big of a deal. There is a ton of information on these slides. Do not try to write down everything, okay? Please do not. I don't even care if you write down anything at all, right? And why is that, Jason?
You want all the attention on you.
Yeah. Well, I mean, that's one way to put it, but really the attention should be on the content, right? Which I am delivering the content. So if you take notes, that's great. If you don't, that's great. The information is going to be available for you. All the slides are there, right? So guess you don't have to worry about it. Also, you can go back and you can listen to this, right? So you can hear it again. It's not going to be a problem. Okay? I'm not certain why this isn't working. It should allow me to write on this, and I really wanted to be able to do that. Let's try to disconnect and reconnect. So it'd help if I could see what I was doing. No, still not working. All right, that's fine. You guys will just have to deal with it. So here are the basic topics for that first sort of chapter that we're going to talk about. We're going to pharmacology in general. We're just talking about drug action, right? We're going to talk about different drugs that you take. When we use the word drug in this class, we're not referring to an illicit drug, right? We're talking about any sort of exogenous, which means outside substance that you're going to take. It's going to mimic an endogenous substance, right? So something that your body already creates. Otherwise, it wouldn't work, right? That's how receptors and this whole sort of ligand receptor thing works. If that doesn't make sense to you now, just wait. It should at some point, right? So we'll talk about all kinds of fun things. Most of the sort of drugs that have been used historically were naturally occurring substances, right? It's actually this interesting sort of, Jason's writing that down. That's a great thing to take a note of. There's actually this interesting jaw they found recently of a Neanderthal. And it is tall, by the way. You don't pronounce the H, just as a heads up. It's because it's German for valley. It's the Valley of Neander, right? It's not, in case you didn't know that. Same reason, like, Cro-Magnon is incorrect, because it's French, right? So you wouldn't say Cro-Magnon if you were from France, right? It's Cro-Magnon, so to make sure that's correct. You didn't know that, did you? This is great info. So they found this jaw from a Neanderthal, and what they found inside the jaw was really interesting because they found like some willow bark, right? And inside willow bark is like salicylic acid, right? Which is the same stuff most of you take now for pain management, right? So if you take something, it's in there. So they also found this guy had like an abscessed tooth, so they think he was actually chewing on, that bark as a medicinal substance, which is kind of fascinating. That medications have been around that long. There's still a ton of herbal medications that folks use. A lot of the medications that even are not naturally occurring substances are based on naturally occurring substances, right? So somebody said, hey, I don't know, what's a naturally occurring thing like opium, right? So that's derived from a naturally occurring substance. Somebody's like, wow, that's pretty awesome. What if I can make that even better, right? And so these biochemists put their heads together and they come up with a lot of these synthetic opiates, right, that you can take for pain management now. Not a big deal. If we're talking about neuropharmacology or psychopharmacology, these are different. We're really thinking about the nervous system. For us, we're going to think about the nervous system some, but we really want to think about how this is going to change, behavior, right, and mood. Okay, so these are things that you're focused on, right? I mean, that's you. Most of you are in a doctoral program to help people improve their mood and change their behaviors, right? So that's really, you're all just in that mind manipulation field. That's true, right? Oh, finally. Well, whatever. It's good enough. All right. So there we go. We just want to think about how we're altering the nervous system to alter behavior. For those of you that did not take, how many of you have taken like physio? I know you all had to take Biobehavioral. Right. See, that's, Cassie, I love that face.
Yeah.
That's how you know someone's made it through Biobehavioral. Like that, you know, just one side, right? So hopefully you understand that the nervous system influences behavior, right? So that's kind of how this works. It's the originator of behavior, right? And so we're going to try to alter the function of the nervous system to alter behavior, right? Not too big of a deal. If we use the word drug action, this is a really complicated definition. We're just talking about what changes the drug makes when it binds to a target site. We're going to really be thinking about sort of the molecular changes. You know, that's one of the things we're going to think about. If we want to think about how those molecular changes alter physiology or psychological functions, then we're talking about drug effects, right? So if we think about an antidepressant, for example, the drug action is going to be how that particular molecule interacts with the receptor, right, at that level. If we want to think about the drug effects, that's when we're going to think about, you know, positive mood, right, and things like that. Okay. This is important. Where the drug does its action may be different from where it has its effects, right? Okay, so that's something to keep in mind. The site of action might not be the same place where you see that effect, so those can be two different places. When we talk about drugs, this is a no-brainer. You want to think about the therapeutic effects. That's why you're taking the drug, right? That's the thing you want to fix, right? Anything else is going to be called a side effect. Okay, you guys hopefully know that, right? All medications can carry potential side effects. Some are okay, some are not okay, right? And you and your prescriber need to figure out the balance between therapeutic effects and side effects, right? There are a ton of medications out there that have hardly any side effects, right? Tylenol, for example, right? The side effect profile for Tylenol is pretty minimal, right? How many of you even think about the side effects? Nobody, right? But there are side effects potentially, right? So there are things you should probably consider. If you think about something else like valproic acid, right? Especially if you're pregnant, okay? That's got a pretty dangerous side effect potential, right? Especially when it comes to like birth defects and things. So those are things to consider. Not a big deal here. We've got specific, we're just talking about biochemical stuff. Non-specific, these kind of depend on you. There are, and we'll talk about some of this evidence that indicates that your sort of expectations can affect, right? So how many of you have heard of the placebo effect? We'll talk about that a little bit. That's like a real thing, right? It's not a fake thing, right? Even though it's not really something for you. This is why it's so difficult to get antidepressants to market, right? Because most of the time just giving someone a pill and telling them this will make you feel better works just as well as giving them a pill that you actually think will make them feel better, right? So that's it's very difficult to get antidepressants to market for that reason, because you got to be better than nothing, right? And sometimes nothing's pretty good. So that gives you guys like a ton of confidence in your job, right? You can just give someone a sugar pill and they'll feel just as well as if they come to talk to you. You guys don't think about these things, do you? See, now you got a benchmark, right? You got like a threshold. I've got to be better than a placebo. It's tough out there. All right, so there's placebo, non-specific. We talked about this. Usually you're taking a pharmacologically inert compound. That's a really complicated way to say it doesn't do anything for you, right? If it's pharmacologically inert. But again, it can have therapeutic and it can have side effects, right? You can, which is kind of crazy, right? You can induce negative side effects in someone with a placebo by telling them like, hey, this could give you, gout. I don't know, I'm just making up something no one wants. This could give you gout, and people are going to complain, oh man, my joints hurt, like I've got gout, right? It's nothing. So there you go. That's kind of fun, right? I think we've all experienced the placebo effect, right? How many of you as a little kid, your mom was like, oh, let me kiss that and make it feel better. That did absolutely nothing for you except probably put bacteria in the wound and possibly like lead to an infection. Right? Hopefully she used some Listerine. But see, you should think about these things. Right? Nobody thinks about that, right? Odds are, like, the same bacteria that are in her mouth are probably in yours, right? Because you're genetically quite similar. You're eating the same foods and you're living in the same place, right? So your bacteria profile is going to be similar. Could be different, but it's probably going to be similar. So you might be okay. Again, the placebo is kind of cool. It's got that mind-body thing. It's really interesting to kind of think about this. And again, it can enhance therapeutic effectiveness, but it can also sort of hurt you as well if you focus on those side effects. So placebos are very inexpensive. Right? Don't cost anything, really, right? Just take this. It's magic water. It'll make you feel better. I don't know. The nice thing about placebos is, guess what? They don't interact with other medications. This is a big concern, right? Drug interactions. Because you can take one medication to fix one problem, and you're taking a medication to fix another problem. The two of them together may make a third problem for you. And that is obviously a problem. What are the explanations for placebo effects? We're not going to really go into this too much. Obviously, Pavlovian conditioning can play in this, right? You know, your classical conditioning. You take a pill, you feel better, so take a pill, you feel better, right? I mean, that's how that works. If you do that enough, then you're going to expect that. You've also got these expectations, social learning, genetic variants. These are all things that can affect placebo. Here's a nice flow chart for you. So you could just replace this with you if you want, as the right, and then symptom improvement. Kyle, it's not too late to change your program.
No, I think it is.
You think it is? You think it is? Yeah, you guys are too far into this. There's the nocebo effect. This is, I've been kind of referring to this as the placebo, but it's those negative expectations that can cause greater side effect occurrence, right? So we call that the nocebo. I don't know if you think that's cool or not. It's kind of weird, but it's the same idea. Again, placebos are used to evaluate the effectiveness, not a big deal. You always want to do things if it's double blind, right? That's the way to do this. That way nobody knows what's going on, right? Because if somebody knows what's going on, they can, obviously, right? They can influence the way that you feel about something, and then they can affect your expectations, which, as we just discussed, can have an effect on the outcome. So anytime you do research, you should never know what's going on. You should always be completely blind. All right, what are some other things we want to talk about? So how do we actually determine drug action? One of these is going to be the concept of bioavailability. This is really a complicated concept. It means how much drug is actually there in your blood that's free so we can actually bind it to targets, right? It doesn't really matter how much drug is in your body if it's all bound up to something, right? If it's not actually free floating and out there for you to attach to those target sites, right? So you want to make sure it's out there and it's free. Not a big deal. There are some pharmacokinetic, and when we talk about this kinetic, we're talking about movement, right? So we're thinking about how does this drug move through your body. This can obviously affect bioavailability. All right. These are your basic pharmacokinetic factors, right? When we're talking about how a drug moves through your body. We want to think about the route of administration first. There are multiple ways, and we'll talk about these, that you can take a drug. Some drugs only work through a particular route, right? There's some particular things about that it's got to go in that way because other ways are not effective for various reasons. Some drugs you can administer multiple ways. We've already talked about cocaine. How many different ways can you take cocaine?
A lot.
Yeah, like a lot, right? You can inhale this. Okay, so that's one way. You can inject it. Right, that's another way. There's just two easy examples there for you. I suppose you could just mix it in your protein shake if you wanted. That might work as well. But routes of administration makes a difference. Some drugs are degraded by stomach acid, right? So you don't want to take that as an oral form, right? Some drugs you can take orally, but you might not want to if you've got the vomits, right? So then you got to go in the other way. So that works sometimes. They do that sometimes with like nausea medications, right? You can take those as a suppository. Just, if you're just going to throw it up, there's no point like putting it down the same hatch. So you got to go in the other direction. For those of you that don't know, your intestine is a great place to put drugs because it's got all these fun little fingers that absorb things like nutrients, and you can absorb drugs that way quite easily and get it into your blood supply. I mean, that's what your digestive system does, right? It just absorbs things and sends it to the rest of your body. So once we've taken a drug, we've got to absorb it, and we do have to send it elsewhere, right? So for example, you're going to take Tylenol. Does your stomach hurt? No, let's imagine it's your knee that's bothering you. So you've got to send that, those molecules to your knee so you can kind of block those pain receptors and so forth. Once we get where we belong, we've got to bind to a receptor or some kind of target site. This is where it becomes really important to think about the shape of these molecules, right, and the shape of your receptors, okay? And so this interaction is what's really important. And when we talk about, there's a word we're going to use called affinity. It's not going to work. I'm going to have to write it out. It's going to be tough. It starts with an A. It's a double F. I don't know why it's doing that to me. Affinity. So affinity is the strength with which two things will bind, right? Like how tightly are they bound together, okay? When we're talking about affinity when it comes to drugs and receptors, we're really thinking about how well do those shapes match, right? Okay. How many of you have had that little kid's toy where you've got like, right? And if you push hard enough, it'll fit, right? Okay. That's not really good affinity, right? But great affinity is when you drop the square right in the square hole and just go straight in, right? Okay, that's what we're thinking about here. Now, most of the things that are naturally occurring don't have as high of an affinity as the synthetic version or the synthetic sort of variant of that, right? And the reason for that is we've intentionally designed the synthetic versions to have a higher affinity, right? If it doesn't have higher affinity, why would you use it, right? Just use the naturally occurring version of whatever that is, whatever receptor you're trying to alter its activity. Just use the naturally occurring molecule or substance and you're fine. If you need something that's more powerful, you want something with higher affinity, right? A greater ability to bind, to stay bound, and to actually operate that receptor open or close. Okay, so that's what we think about there. Thankfully, most drugs can be inactivated, right? That's an important step. Okay, how many of you don't have to answer this because this is personally identifiable medical information. How many of you have ever had to take a medication more than once? Probably every medication you've taken, if you've taken one, you had to take it more than once, right? Okay, because it becomes inactive at a certain point, right? We break this down, we break it down into its metabolites, right? And then we typically will excrete those metabolites. Most of the excretion is going to occur through your urine, okay? So that's fun. Well, I mean, if you were trying to like excrete it through your eyes, that doesn't sound like as much fun, does it? Okay, so there you go. Excretion typically is going to occur through through your urine. Your kidneys are great filters. That's what they do. They pull out things that you don't need. There are a few other excretion pathways, through your feces or sweat. Sometimes you can excrete things that way. Breath. Sometimes you can breathe out stuff too. Right? Things will come out in your breath. That happens. But we're going to think about excretion primarily through your kidneys. In order to excrete things, so this is a real concept you should understand. We have to think about lipid solubility. Right? This is a really important. It really is. It is one of the most important concepts to understanding how your body works. Is understanding lipid solubility. You are mostly just a sack made of lipids, right? And so all of your, I know, right? You're thinking really nice of yourself, right? Anybody Star Trek fans out there? Nobody's going to admit to that. There's this particularly interesting description of humans called ugly bags of mostly water, which I thought was particularly great. It was like a silicon-based alien was like trying to taunt carbon-based. Anyway, I guess you had to be there. But it's a great insult. Like the next time you get mad at someone, you're like, you're just an ugly bag of mostly water. You're welcome to do that. So to excrete something, it has to be less lipid soluble, right, than what it was originally. When you take things that are lipid soluble, they can like slide in and out of your cells because again, it's like a phospholipid bilayer. Okay. If you think about something like alcohol, that guy is really lipid soluble, right? I think it's slide right in, gets into your brain, and you can do all kinds of weird things, right? And that's how it works. Other medications work the same way. They need to work that way, particularly if we want to get into the brain, right? Because there's something in the brain that protects it called the blood-brain barrier. And we abbreviate that, just in case you want to know, as 3 Bs. It's not the Better Business Bureau, it's the blood-brain barrier. Yeah, I really don't know what's wrong with this thing. So, the blood-brain barrier, very important for protecting your brain, but if you want to take a medication that's going to affect your nervous system, you need to bypass that blood-brain barrier, right? And so you want to have something that's lipid-soluble to just slide it right in there, do its business. Later, you want to make it less lipid-soluble so that you can actually get it out of your kidneys. If you don't make it less lipid-soluble, your kidneys will try to grab onto it. They're made of lipids too, by the way, and it'll just slide right back into your body. Okay. So that's excretion. That's kind of fun. Here you go. We're talking about binding. Tons of places where you can like store things. Bone and fat happen to be one. They're kind of these like storage depots. Again, we talked about excretion through most of those sites. Most of this inactivation is going to occur in the liver, although some of it occurs other places, right? The primary place we want to think about, though, are liver enzymes, right? You've got a ton of liver enzymes that are going to break down medications. It's actually important to understand the function of your liver enzymes so you can actually start to think about whether or not this medication is going to work for you and how much of that medication to take, right? We're not, unfortunately, at a point where we do like a nice liver panel for everybody before we give them a medication. That would be awesome, right? Because then we wouldn't just be like dialing up and down things or giving you something that might not work, right? Because your liver may or may not break that down appropriately. Some people could break things down faster, some people slower, right? There's a ton of variation in these, we call them CYP50 enzymes that break down most of the drugs that you'll take. So there's a lot of variability there. This is why you might see two individuals that are matched for age, sex, and weight, and they might be taking drastically different, doses of a medication. That could just be because of their liver enzyme functions. Could be different. All right. Other questions? How's everybody doing so far? Who would like to take a break? Great. Drug effect is going to depend on how quickly it gets to its target. Not a big deal. Frequency and history of prior drug use is important, right? So we will talk a little bit about tolerance mechanisms. Okay, there's specific tolerance and there's some like non-specific tolerance mechanisms as well, right? And this can be related to receptor availability. It can be related to induced enzyme activity, right? So if you've increased your enzyme activity. This particularly works with alcohol, right? So the more alcohol you drink, sort of up to a certain point, over some period of time, you'll start creating more alcohol dehydrogenase, right? So you can break down, and that's why you could drink a bit more over time, right? If you continue to drink for some period of time. All right. Basically, there are a couple ways you can go. You can go in through the GI tract or not. GI tract tends to be slow. You get some variable blood levels. That's okay. Oral administration, we've talked about that. There are advantages. It's got to be safe. It's economical. Most people can do this on their own, right? So you don't have to have a medical professional actually do that for you. It does have to make it through your stomach acid. So there's that. Insulin, for example. How many of you know someone who takes insulin? Like everybody does, right? Like everybody knows someone who takes insulin. You can't take insulin orally because it's broken down by stomach acid. That's why they have to do injections. It's not just because we love stabbing diabetics. At least I don't like stabbing diabetics. They got their own problems. I like stabbing non-diabetics. That's much more fun. Absorption. Not a big deal. What it affects absorption, a lot of things. Sometimes the amount of food in your stomach can make a difference, right? That's why they often tell you, take this with food, right? Or it can be taken with or without food. Kind of depends on the medication, okay? So that's going to make a difference. Physical activity, right? So that can, you should always take medication and then run 10 miles. I don't know. You should probably run 10 miles anyway, just for your general health, right? Like 10 miles over like a year. Spread it out. When we're thinking about metabolism, there's what we call first pass. Okay, we're going to get in the liver. This is going to be the first pass at chemically changing something. We're going to take it from whatever form it was in that you ingested or injected or however you put it in your body, right? And then see how we're going to do something to it. We've got enzymes that are going to break it apart. Often when we do this, we're going to make it inactive, and then we're going to excrete that. There are times where you take something called a prodrug. Has anybody heard of a prodrug? This is after they've given up their amateur status. A prodrug is when you take a drug that's actually not active, right? And so you're going to take something, and that first pass metabolism is going to turn it into the active drug that's going to have the effect in your body, okay? So sometimes you'll do that. Right? You'll take a prodrug, and then it will it'll then become that metabolite will be more active and more useful to you. Not a big deal. Here are the.
Like a probiotic, like.
So I think those are a waste of your money.
I don't think. Like,
I didn't think you
when I
did.
was on an antibiotic, they said to take that with
Yeah, I mean,
And I
most of the
wasn't
most of the probiotics you take are like destroyed before they make it anywhere to help you. But that's the way that goes. That's a little different. But they use the same sort of precursor there for you. Yeah. They try to trick you. I tried that Activia for 3 days once. Just as a side story. I thought I was having a heart attack the third day when I woke up. I'm serious. Like, I know Jamie Lee Curtis, I mean, things must move through her like a freight train. But I took that Activia and I felt jammed up to here. Like I couldn't breathe. I woke up and my wife thought she was going to have to take me to the hospital. It was awful.
Why? What?
It was awful. I didn't think I needed to take it anyway. Like my wife said, you need to eat this Activia.
Yeah, why would you try it?
She told me to. So I did. Right? That seems like a reasonable reason. It was a good answer. She said, you should eat this. I'm like, okay, I will. So I did, and it made me sick. It was awful. So I don't recommend it. For I don't know. It was a rough experience. It took like a whole day before I felt better. I was like, oh, that is awful.
Are you sure it was that?
Yeah, that was supposed to do the opposite. Yeah, that was supposed to help you with that.
I don't think I needed help with that. And so
So it just fucked you all up.
it was awful. It was a horrible experience. I even stopped watching True Lies because of that. I'm sorry, I was trying to think of like a bad Jamie Lee Curtis movie, and that's like the first one that came to mind. Anybody see that one?
Is that the one where she gets like naked and dances?
I have no idea.
Oh.
I really don't. It's the one with Arnold Schwarzenegger in it,
Yeah,
right?
that's that one.
Oh, it is? Who knows? They cut that part out on TBS, I'm certain.
Yeah.
Different routes of administration. You probably have heard of most of these. Kind of an important one to think about is inhalation. A lot of people will get that confused with snorting, right? They're two completely different things, okay? Snorting is going to take advantage of the mucous membrane in your nasal cavity, right? Which is very similar to like sublingual, right? When you put things which people will also confuse with oral administration, those are two different things. That's going to be an absorption through a mucous membrane, right? And so that's a different way of administering a drug. For inhalation, it's actually got to get into your lungs, okay? So it's got to be in some sort of aerosol form or some smoke form, right, to actually get that in there. Okay,
What
so
would it be called if it, like you put it like on your skin, like something like that?
that's topical. Yeah, that's topical administration. Lidocaine, for example, is administered that way. I don't know if you guys have ever used lidocaine. They'll put it in like pain relieving creams. Okay, so that's Benadryl creams, anti-itch creams. That's all topical administration. Those are not things you want to like rub inside your body somewhere. Let's see, rectal administration. That one's pretty obvious. Great for infants, folks who are vomiting, unconscious, or if you can't swallow. So keep that in mind. IV. IV is actually very quick onset, which is great if you need to get the medication quickly. Not so great, again, if you're going to have like an overdose or an allergic reaction to that. Very little time to reverse that action, right? So once you've squirted it in your veins, then that's kind of, well, good luck. Because it's going to do what it's going to do, and you're not going to be able to stop it. If you take something in your stomach, you can always get your stomach pumped. Right, that's something fun. So you can reverse that. There are some other hazards to IV injections versus other forms. Some of those include infectious diseases, right? If you're using this, especially with drugs of abuse, folks aren't always like sterilizing their needles. The needles aren't always available. This is sort of why like free needle exchange programs are helpful. At least we think they are. We don't really know. There's not a lot of data, right? There aren't a lot of people collecting data on these things. They sound like they would help, right? But we don't really know. So there's actually some folks here working on that to figure out if they're helpful. I guess they're better than not, right? I mean, I think you should do them. I mean, intramuscular, those are always fun. Sometimes those hurt. I mean, like, I guess all shots could hurt, right? But sometimes these will burn if the pH of the substance is different than what's inside your body. I feel like you're burning a little bit if you get a shot. They'll give you like a flu shot. Who's had a flu shot? They'll do that usually in the shoulder, right? In the deltoid. It's kind of a place to put that. So that can happen sometimes. That's where they gave me the rabies vaccine. Had that one. That one hurt.
Are you supposed to get that on your butt cheek?
They did in my arm. 3 times.
You're blessed.
Yeah, I guess. Did you have to have the rabies?
No, my friend did. It was in the ass 3 times.
Oh. Yeah, no, this was a preventative though. So I didn't like have rabies. It wasn't like they thought I had rabies. This was like to make sure I didn't get rabies.
What happened to you that they thought you might have rabies?
I was going to do some work with ferrets, and ferrets tend to be rabid. I guess. So they were afraid I was going to get bitten by a ferret while I was trying to, like, stick things in its brain, and that I would get rabies. So I was going to use an anesthetic on the ferret, not on me. But anyway, I had to have the rabies vaccine all the same. I worked at it was at a hospital at the time, and they were just really overprotective about those things. Like every year I had to go in and get a TB test. I had to get a flu shot. I had to go in and get fitted for a respirator. Like every 6 months, I think it was. Like I had to go in and like make sure a mask would still fit my head. It's like, yeah, it works. And I'm like, okay, well this is your size. I'm like, I thought they were all the same. And just stick it on there. But it was like a trauma level 1 hospital, so they were a little particular about things. IP injections, you're probably not going to get one of these. But if you were a rat, you might. It's when you jab them in the stomach, right? And you can inject things in there through the abdominal wall into that space around your organs there. Huh? There's not a lot of other places on a rat where you're going to jab it, right? I mean, if you think about it, like, it doesn't have a lot of muscle, so if you've got a needle, right, it's got to be at least like this long if you think about it, right? And you can't, like a needle like that's not going to do anything, so it's got to be like at least this long. And if you like stick that into its like shoulder muscle, it's going to like come out the other side. So you got to like stick them in the stomach. No, seriously. And then you're not, I mean, I guess you could try rectal administration, but I think stabbing them in the stomach, they're going to, going to take that just as well. Subcutaneous is when you're going to inject things below the skin. Quite often now they have these like pellets, right? So you can like inject a little pellet that'll release yeah, that'll happen. You can release the drug over time, right? So there's extended release things. Or they have like, sometimes they have little devices, right, that'll deliver little pulses. We talked about inhalation.
I have a question.
Yeah.
So how do you know the difference between, like, I guess just doing it right under the skin and then like in the muscle? Like how far would you have to go in to get to the muscle? Does that make sense?
Yeah, no, it actually does. I mean, you got to go pretty far really to get down to muscle, right? So you got to kind of go, like, if you're going like perpendicular, that's probably going to the muscle. If you're coming in parallel or at an angle, and that's going to be subcutaneous. Okay, does that make sense? That's a good question, though. So there you go. Inhalation is great. Your lungs have a ton of capillaries, so they're going to absorb the drug pretty quickly, right? So it's kind of a fast way to get things in there. Topical, we talked about that. Sublingual, not a big deal. Intranasal, we talked about intranasal as well. You don't have to snort cocaine. You can also snort Flonase, right? That works just, I mean, doesn't work just as well. But it's the same route of administration, right? Not too worried about that. Transdermal, this is going to be like through the skin. These work for patches, right? Anybody have motion sickness? Yeah, sometimes you get those patches, right? And you can...
Straight to the pill.
Huh?
Straight to the pill.
Straight to the pill. Patch didn't work. So there you go, right? So that's fun. Epidurals, those work. That's when they stick stuff into your spinal fluid. So that's fun, right? I don't know if anybody's had one of those before. Yeah, no, I would avoid that. So one of the best ways to avoid that is like don't have kids, right? Because that's kind of common. They'll give you an epidural when you're like trying to squeeze something out that's a little larger than the hole it's coming out of. Can obviously cause you some pain. I had one of these once when I broke my toe, and they had to like cut my toe open to put the joint back together. Yeah, that was fun. And so they gave me an epidural, and so I was numb from like the waist down for a while they were like working on my toe. Yeah, that was kind of fun.
Why would they do it?
Is that safer than?
I don't know why they didn't want to intubate. They decided not to for whatever reason, and I don't know. I no lasting problems from it, so I guess they made the right choice. I mean, I've got a scar on my toe, but I don't think that was avoidable, so I'll go with that. I kicked a kid in the shin is what happened. Yeah, I was in a martial arts class, so it wasn't like I was like randomly kicking people. And I was a kid as well. I should make that clear. It wasn't like I was an adult walking around kicking little kids. Sometimes you need to put things in your brain. So you can do intracranial or intracerebroventricular. That's going to go right into the ventricles. So those are other ways that you can administer drugs as well. Why would you want to do that? Again, if you want to bypass that blood-brain barrier, right? You need to get something directly into the brain so that it can have some action. Not going to be the preferred way to go because that's going to require you to like cut a hole somewhere, like to get in there. But there are times where that would be a necessary thing to do. We talked a little bit about pumps. Not a big deal. A lot of these will, send antibiotics into your cerebral ventricles. Again, that's kind of a severe situation, right? If you got to put an antibiotic straight into your brain. Avoid those like brain parasites. We could talk a little bit about gene therapy. I don't know that that's too important to you guys. Gene therapy sort of works sometimes. It's not the best. It's kind of cool though. I mean they've got a nice gene therapy now for color blindness, which is kind of cool. They can give color vision back to monkeys that are colorblind. They should be doing that in humans pretty soon. And I know you're thinking like, well, who cares about color blindness? But if it works for color blindness, then eventually you can do other forms of blindness, other things. So it'll be kind of exciting. Usually requires the use of a viral vector. So you got to give somebody a virus, or at least part of the virus, not the part that makes you sick, just the part that's great about getting in your cells and tricking your cells into doing other things than what they normally do. You can use that to your advantage. Let's see. Rate of absorption is important, right? You're going to look at like peak levels of your absorption rates, right? That's going to be something you want to think about. There are all kinds of advantages and disadvantages with your route of administration, so you want to think about that. I think for most of you, you're going to be dealing with folks at least who are taking prescribed drugs orally. Non-prescribed drugs they may be taking through other ways, right? And so you need to watch out for that. All right, this is just a nice little chart. I know you guys love graphs and charts, so we'll throw these in periodically so you'll have that. Just showing you absorption rates. Here's a nice little table. Not a big deal. If we want to think about absorption, so we've thought about administration, anything that's psychoactive, it's got to get into your brain, right? And that's really where it's got to go. We've already talked about things being phospholipids. You can read this if you like. Things need to be lipid soluble so they can slip through this phospholipid bilayer. This is just kind of one side of it. There's going to be another one down here. Whatever. And you want to be able to like slide in between these guys so you can get in and out of cells, right? This is where lipid solubility becomes very important to you. I call it a key to transcendental enlightenment. Once you understand that, that and like surface area to volume ratios, like once you understand surface area to volume ratios and why those are important, the rest of the world will make sense to you. I promise. Here you go. Here are just different proteins. Not too big of a deal for you to think about, but all of the receptors that we have are going to be wedged in this phospholipid bilayer, right? And they're going to dock into one side of these proteins and cause changes on the other side of those receptors or whatever, and then they can open ion channels, close ion channels, block ion channels, right? This is kind of how the process is going to work. Not a big deal. If it is lipid soluble, you can often get in through diffusion. Not a big deal. You've got your concentration gradients will push that through, so it's not too big of a deal. You can actually get in there. Heroin is actually more lipid soluble than morphine. That's why heroin is more effective, right? And not effective, not necessarily in a good way at this time, but it's more effective about getting in and doing its action because it is has that quicker onset due to its higher lipid solubility. So that's interesting, right? I am not going to expect you to know much about like this PK alpha stuff because I feel like that's going to lose probably 5/4 of you because some of you are going to get lost twice on that one, and I can already tell. But it's got to do with how lipid soluble something is. It's got to do with its ionization and depends on like pH and some other properties that PK alpha of the molecule, right? So pH is important as well, right? So making sure that you know, I don't know, what was that pH balanced for a woman? Anybody remember those commercials? What was Dove? Not Dove. Secret? Some deodorant, right? Strong enough for a man, pH balanced for a woman. It's a brilliant marketing campaign, which meant nothing, because pH is the same, right? Inside men.
Yeah, it's for your vagina.
I think it's.
For men.
Yeah, that's not.
There was a deodorant campaign.
Oh.
There was,
There's
right?
also the
Like
vagina
early 2000s,
stuff.
I feel like.
Yeah, I was alive.
pH balance.
It was something like that, right?
I don't
Strong enough
My-
for a man, pH
My
balanced for a
secret
woman.
deodorant says pH balanced on it. I
Yeah,
don't know why that
It
matters.
does.
it doesn't matter. I mean, you don't want to rub like
Anything, does it?
acid in your armpit, but other than that, I mean, it's not really gonna make it. I mean, like wipe on some hydrochloric acid's a bad idea, but anything else is probably gonna be fine. You don't have to worry about it too much. pH is going to be important though when we're talking about how fluids move through your body. Most of you are not going to be concerned about that, right? Because you're not going to be like controlling people's pH or the pH of the environment. So, but this gives you an idea of different pH ranges. Acidic numbers are low, basic numbers are high. Your blood is usually around 7.4, give or take a little. Give or take a lot and you die, so keep that in mind. This is why high blood pressure is such a problem, right? Because you blow all the protein out of your urine, right, the albumin, which is really great about latching on to hydrogen ions, which keeps your blood pH where it belongs. So if you have high blood pressure and you start shooting all that protein out through your urine, instead of keeping it in your blood, you can get acidosis. So there you go, like lay off the salty foods. Don't worry about this too much. That's going to confuse you. This is probably going to confuse you as well. If you're interested in it, go back and read it because it's about drug ionization and things, but I really don't think most of you are going to get much out of that. But it is kind of interesting on some level. Other things that affect absorption, like how quickly your stomach empties, right? Your small intestine actually has a lot more surface area than your stomach, and things move through it more slowly. Your stomach empties after a couple hours, right? It could take another 20 hours or so to get everything through your intestine and back out somewhere into the free world. Size and sex makes a difference as well. Larger people have more body fluid. It's just the way it works, which would dilute a drug, right? So I always like look on this like, so I like take Advil periodically, right? And I think about this, Olivia, and it's like, if you're 12, take 2. I'm like, man, I'm like twice as big as most 12-year-olds. Shouldn't I take 4? Right? And I wonder, like, is 2 really 12 and up? That's like it's a big difference. I think about my nephew. He's like 11. I mean, the kid probably barely weighs 75 pounds. I'm like, that's nothing. I mean, so I can take a few extra, right? Just take a handful. I don't think it works that way. I think it's safe to do Advil that way, right? I think it's safe to just like take a handful of Advil periodically. I wouldn't take like a handful of morphine. If they told you to take like one little pill, like, I'll just drink this down, it'll be fine. You don't want to like tap the IV bag and start drinking it. I wouldn't advise that. There you go. Females also tend to have less body fluid than males. That's interesting, I guess, right? Whatever, not a big deal here. Capillaries, pores. Drug redistribution, this is kind of interesting. If you've taken a bunch of this drug, right, and sort of stuck it somewhere to hold on to it for a bit, when your plasma levels fall down, you'll like dump that drug back out into your plasma, right? Because it's all about concentration gradients, right? And so when you open up a door and then things can rush out, right, because the concentration is kind of lower outside of those storage depots, right? So not too big of a deal there because you always want to try to maintain that equilibrium. So not a big deal. Cerebrospinal fluid, we talked about that. We talked about the blood-brain barrier. You can fly through this. Hey, this is like a chunk of your brain. That's something. And you've got a lot of blood going in here in these meninges, right? Okay, so you can get into those. It's going to supply blood deep into your brain in a few places, so you want to keep that good to go. Brain capillaries actually have a really interesting morphology. They actually limit the way that molecules can hop out of the capillaries, right? Most places there are these holes called fenestrations, right? They're just kind of from the Greek word for window. So if you throw something out your window, you have defenestrated it. So there you go, right? Something fun. So they have fenestrations. There are spaces between the cells, so it's really going to allow things to flow in and out sort of freely. In the brain, it doesn't really have that because it's really going to minimize the movement of those molecules. Again, that's why you want things that are lipid-soluble because they can slide in and out quite easily. Right? There you go. There's a fenestration. In the brain, we also have all of these like astrocytes kind of packed around here, right? And normally those astrocytes will help pull things out and give them to your neurons as they're needed. All right. Again, that's why ionized or non-lipid soluble, it's the same thing. Molecules are going to have a difficult time getting into your brain, but things that are lipid soluble will be able to do that more easily. Oh, hey, who loves projectile vomiting? We should talk about that a moment. There are a couple places in your brain where the blood-brain barrier is weak. One of those is known as the area postrema or the chemical trigger zone, right? What will happen here is if you have some kind of toxin in your blood, it'll induce this vomiting to try to empty out your stomach if you've ingested it. In that way that's helpful. If not, well, you're just vomiting for the fun of it. Again, it's important to know what will go across the blood-brain barrier and what won't. Okay, so that's kind of fun. A lot of this has to do with the shape of molecules. You know, I'm just going to draw some random shape. It doesn't matter to you what it is, because you're not going to know. But if it's got like a polarized end or it's ionized, it's going to be difficult to get in and out of that blood-brain barrier. If it doesn't have that, then it can slide in and out. It's kind of easy to do. The placenta, right? All of us have been close to one of those before. At least I think so, right? It would be kind of tricky not to. Right? I think most of you spend several months close to a placenta. I guess that worked for you. That's actually a pretty good barrier between the mother and the fetus. Unfortunately, there are things that will cross that placental barrier, right? And that can cause, teratogenic effects, birth defects, things like that, right? Alcohol is one of those things that will just right through that placenta, right? And so how many of you have heard of like fetal alcohol syndrome? That's a thing, right? It's unfortunately more common than it needs to be. Newborns, this is a big deal, right? Especially in this area. Kids being born addicted to opioids, right? Because the mother was using drugs at the time, and this can happen, and the kids still have that withdrawal. So that's kind of an unpleasant thing to think about, but from a pharmacological perspective, it's sort of interesting, right? Obviously, don't do cocaine while you're pregnant. I mean, it's like a no-brainer, right? Let me just put that on there. Other things you've got to really be careful about as well. We've already talked about this. We're not really concerned about x-rays, how that affects babies, so we'll skip through that. We already talked a little bit about drug depots. This is where we're going to put things that don't have, where it's not going to have an effect, right? It's just going to be an inactive site where we're going to store the drug for a while until that plasma level drops down. Muscle and fat are places we can do that. Again, that protein albumin, we talked about that a bit. We can put it in there. They're not going to go to the liver, right? Because they're not going to be metabolized. It's just going to hang out there until that plasma concentration drops, and then the affinity is going to shift a little bit, and we're going to release that, right? Because, Jason, we're dealing with affinity issues again, right? If the affinity for this binding site is high enough, then we'll hang on to it. But once that concentration gradient becomes more powerful than the affinity for us to hold on to it, we'll let go of it. This is exactly how, like your red blood cells let go of oxygen, right? There's a pretty high affinity for the molecules inside your red blood cells for oxygen, right? So oxygen will latch onto that. Except when you get into an area where there's a low oxygen concentration. There's some deals with like CO2 and pH as well that's going to affect this. But then they'll dump off the oxygen and then pick up other stuff later. So that's kind of a fun thing to think about. This depot binding actually causes a delay in drug effects, right? Because we're going to be sucking up a bunch of the drug, and we're not going to be releasing it until later.
It's like some antidepressants, or I've heard some antidepressants you have to take them for so long before they build up in the system.
Yeah, absolutely. It can take some time, right, for particular drugs for you to get to a steady state, right? Because you want to get the concentration high enough. You're going to be breaking some of it down. You're going to be storing some of it. You need to make sure you get there. This is why some folks will have different responses to drugs as well, right? You can, again, put two people on the same antidepressant, and depending on how well, their enzymes work, how well they have the depot binding, it can really make a difference. Some people may have to take it for a week, some people 2 weeks, it just depends. So there you go. Which is really like not a great thing to do, right? Somebody comes into your office and say, man, I'm depressed. And you're like, okay, take this pill and come back in 2 weeks. We'll see if you're feeling better. What can happen in 2 weeks to somebody who's depressed? Yeah, but Jason, what was that face? That's the official like suicide face, isn't it? And not to laugh about suicide, but I think if you guys don't, you guys will go nuts, right? Dealing with people like that all the time. So you got to have a little bit of humor about it. Maybe why I'm not a clinician. Suicide, haha, that's a funny one. But I think, you know, it really becomes a real problem when you're trying to treat an individual with an acute, severe problem, right? And they're like, okay, well, come back in 2 weeks, we'll see if this pill worked. And I think that's one reason there's a lot of work that needs to be done in psychopharmacology to develop better medications. I think, one, we need a better understanding of what's actually going on neurologically in folks who are depressed. Right now, we're just sort of shooting blind, right? Like, well, this pill makes some people feel better, so we'll let you try it. It's like, okay. It also makes some people like grow extra arms, but you know, whatever, because there are these side effects, right? What's a big side effect for antidepressants? That, like sexual side effects, right? And nothing will get you out of depression like a good sexual dysfunction. And that's like, boy, you're feeling bad. Yep. Wait till you give that a try. Nothing's working like it should. Then you know you got something. That's when you know you got a great drug. So there you go. We do want to talk about this concept of selective and non-selective binding, right? So similar drugs can actually bind and compete for similar sites, right? So if you take a drug like cocaine, it's sort of structured similar to dopamine. It and dopamine will kind of have a battle to figure out if they want to bind in the same place or not, right? If the cocaine wins, woohoo, you know, you're in for a ride because it's more powerful. It's got that higher affinity, right? And so you've got sort of selective binding. There are some other types of binding. We'll talk about those in a bit. This is important for those of you who've ever had to take a drug test. Everybody got quiet. They started paying attention at that point. Certain drugs can actually stay in your body for a long time. A lot of this is due to that depot binding, right? THC, for example, that's kind of the main active component in marijuana. There are other components that do things. We can chat about those later. Can be detected in your urine for several days after you have a single dose. I don't think most people think about marijuana in doses, right? Like, unless you're getting it from a dispensary, and then you're like, yeah, this is a dose. Otherwise, it's like, no, it's a joint, right? I mean, I think that's... That was pretty... I don't know what that is. You hear that? Doesn't sound good. Let's see. Not a big deal. It's another example of depot binding. Biotransformation. Again, we want to get the metabolites and excrete those. Usually this is sort of an exponential process called first order kinetics. I don't expect you to understand a lot of this, but the basic idea is you've only got like a small fraction of places that are going to work to break this down, and so you're going to be breaking it down. That's why we talk about like half-lives and things, right? Okay, so this is sort of for first order kinetics. This is time and half-lives. This isn't like actual time. Different drugs have different half-lives, right? So they'll last for different amounts of time. Jason, this sort of goes back to your question of how often do you need to take a medication, right? To make sure that you keep, let's say you want your concentration to be sort of here. Well, you're going to take some and it's going to come down, and you want to take, and so you want to get to where you've got that steady state based on your, the metabolic kinetics. Not a big deal. Half-life. The problem with the really long half-life is that it can lead up to accumulation. It can cause toxicity and side effects. If you want to take something once a day, if your half-life is about 8 hours, that's pretty awesome, right? Because then you've gone through a couple half-lives by the time you take the next dose. Your concentration is never going to get too high, but it's never going to be too low. Kind of stay where you need to be, right? This is why it's important to read if you are on medication, like what it tells you to do if you miss a dose, right? Because if it says don't take it, just take it the next time, and you go like, nah, whatever, and then you take like 2, you can really screw this up a little bit, right? And that's not going to be fun. Here you go. Here's some general half-lives. I love when they put like the street or trade names on there. I just love these, right? Because big C, right? I mean, but they didn't even capitalize like the. So I don't know this, right? I wouldn't regularly use big C for cocaine. Do they always have the big lowercase? Like, I would think they would have to capitalize the big as well, right? That's what I would do. But what do I know? All right, so again, Jason, you want that steady state plasma level, right? I know you're really interested in this for some reason. I don't know if you got like a fish tank at home and you're like trying to think about like how can I get the concentration of, I don't know, krill to a certain level based on how many like other fish I have that eat krill at a certain rate, right? It really is the same thing as like drugs and enzymes, right? So there you go. Hey, look at that fun thing. I just drew something like that for you, right? And here's a slide in case you didn't like my drawing. Again, this is about the peaks and how you're going to maintain that, that steady state of plasma so that you have that drug effect that you're desiring, right? So then you can adjust up or down from there. There are some drugs that are eliminated in a different way. This tends to happen if your drug levels are high and you've sort of saturated all of your sites of metabolism, right? This happens with alcohol, right? Especially if you take a couple of drinks or have a couple of drinks pretty quickly, right? You're going to be saturating your enzymes that are going to break down the alcohol, so it's going to be at a constant rate. It's not at that exponential rate, right? If you look back at this slide, you can see that it's kind of an exponential decrease, right? It's not a steady decrease. After one half-life, we've gone down like 50%, and then you go from 50 to 25%, and then down to 12.5%, right? And it's a different kind of step than if you were going at a constant rate, right? A constant rate would indicate all of your metabolic sites are occupied. And again, that alcohol is probably the best example for that, at least at the beginning. Once you're out a little bit from taking the alcohol, then you go into that sort of first-order kinetics. Not a big deal. All right, we already talked about metabolism, also known as biotransformation. Most folks will probably just talk about metabolism unless they're trying to be fancy. Again, most of this is in the liver. There are lots of things you can do, different ways that you can break this down. I'm not expecting you to remember that, right, because that's a little more biochemistry than I think you're ready for. So not a big deal. You can slam stuff together, you can rip stuff apart, you can add things to it, right? Methyl groups is a big one. If you methylate things, you probably hear about that. Or you can ionize things. Ionizing them makes them less lipid soluble. So if you were to slap on, something that's got a positive or a negative charge, then it will be harder for your kidneys to let that slip through, right? And they'll just dump it out. Not a big deal. Again, we already talked about prodrugs, so we can kind of skip through that. We talked about enzymes a bit. There's your CYP450s. That's like a whole family of drugs that work to oxidize psychoactive drugs, right? Again, you're going to be focused on psychoactive drugs in your kind of future lives, right? These CYP450 enzymes, again, there's a whole family of these. So it's not just like one enzyme, it's like a whole group of enzymes. These are the guys that do that. There is a ton of variability in these enzymes, right? So some estimates have been as high as 30% of the population have some variation in their CYP450 enzymes that alter the way they break down opioids, right? So that's kind of significant, right? If you're thinking 30% of the people are having some altered drug metabolism, you can really start to think about why are those individuals maybe more or less likely to become addicted to a substance, right? All right, so factors for metabolism, we're thinking about induction of enzymes. You can inhibit enzymes. There are all kinds of different factors here. Competition between drugs can make a difference as well. All of these things are going to work to break down your drugs into their metabolites. If you continue to take a drug, you're going to make more of the enzyme that's going to break that down. That's not surprising. It's possible that some drugs can inhibit the production of enzymes, right? So that's kind of a thing to worry about. How many of you have ever seen on basically every medication in the world, if you're taking an MAOI, don't take this? Yeah. I mean, it doesn't matter what it is. If you take an MAOI, you probably shouldn't even drink water. MAOIs have monoamine oxidase inhibitors. We'll talk more about those later. They have some serious dietary restrictions, right? They have some serious drug interactions because they screw around with a lot of enzymes. For those of you that love wine and cheese, I don't know if there's anybody in the wine and cheese group here. You can't eat wine or can't drink wine or eat cheese if you take an MAOI. So that can cause a real problem. You can die. I don't know.
Is it the fermentation?
So it's like a byproduct of that. That's because the cheese is the same process, right? It's not like you're getting a fresh slice of something, right? Because the cheese has sort of gone through a similar fermentation process to make that. So yeah, MAOIs, watch out for them. They don't prescribe these a lot actually, unless they have to, right? Most folks who would take an MAOI, they're going to try like an SSRI first, because those side effects are better and there aren't dietary restrictions, and so you can go out and have all the wine and cheese you want, right? Well, I mean within reason, because both too much cheese and too much wine, either one will cause you problems, right? So there you go. We already talked about competition, not a big deal. The problem here is if you're taking two drugs that use the same enzyme, they're not going to be broken down fast enough, right? So here's a great example: alcohol and Valium. They don't mix because they're both trying to use the same enzyme for that metabolic process. And if you're overloading that, then one of them is going to get to a toxic level, right? So that's going to be bad. We talked a little bit about genetic polymorphisms, not too big of a deal. This can just really affect your enzyme production and availability. Here's a specific example. Again, it's one of those CYP enzymes. There are some folks who are ultra rapid metabolizers, so they'll metabolize. Yeah, that's something, right? You just waste your money there taking a drug. It's like you take cocaine for 30 seconds and then you're done. You know, it can work that way. So these folks are often non-responders, right? So you might just be pumping somebody full of drug and it's like, man, that's not really doing anything for me. And then so that happens, right? I don't know, and it varies from person to person. I don't know. And then there are people who can just smell a drug and they're like out of it. You know, it happens. My wife is like that with Dayquil. Like she takes Dayquil and it makes her go to sleep. I was like, it's not supposed to. Like, why is that? And I'm over here just like a flask of NyQuil, you know, and I'm like, this is not doing anything. It's like I don't feel any better. I don't feel tired. So.
Do they metabolize all medications fast, or are there specific ones? Because you said different enzymes.
Yeah, it's going to be specific depending on the genetic polymorphism. So depending on which set of genes are different, it's going to be a different set of enzymes that they're overproducing or underproducing, and depending on the. I'm not going to expect you to know which ones, but you know, each sort of grouping of enzymes, it's a different drug that's going to, or a different class of drugs that'll fall into that. So you could be potentially an ultra rapid metabolizer for drug A and a slow metabolizer for drug B, a normal metabolizer for drug C, right? It's going to vary depending on that. And you could figure all of this out with a nice enzyme panel. So everybody should sign up for one of those.
How would you know the difference between tolerance and someone who's just a rapid metabolizer? Does that, or maybe I didn't ask that right, but does that make sense? Like, how do you know?
It does make sense. Tolerance is going to be, so somebody who's a rapid metabolizer, you're going to give them the drug once, and they're not going to respond to it. Someone who has developed tolerance is over time they've had to increase the dosage to get the same effect. That's not to say that someone who's an ultra rapid metabolizer might develop tolerance at a different rate than someone who is a a slow metabolizer, right? So that could have an effect because enzyme activity does play into tolerance. But those are going to be, that's how you would know. So you just get somebody and like, well, you know, I don't know if it's tolerance to cocaine or if you're an ultra rapid metabolizer, so you just give them cocaine once and see what happens. Yeah, maybe you should try like a drug that's not as powerful as cocaine. So just for your own, use there. That's just a chart telling you what I just told you in words. And it's just showing you sort of a genetic breakdown, some different populations. All right, we got to get stuff out. Again, it's going to go through urine, come out through your kidneys. pH is going to play a role again because pH will change the ionization of those drugs. Remember that PK alpha I told you didn't have to know? Okay, we're just coming back to it right now, so you sort of did need to know it. You can alter someone's pH to treat drug toxicity, right? So you can give people a shot of baking soda, sodium bicarbonate, right? And that can actually alter pH in a way that's going to help you out if you need to get some drugs out of you. Not a big deal. We're not going to worry about therapeutic drug monitoring. It's pretty easy. You just keep taking blood samples and see how much drug's in the blood. That's really great because over time you can say, well, we need to give more or less drug and to maintain that therapeutic treatment level. All right, how are we doing? We're just cruising along, are we? Pharmacodynamics. Think about how they move within the cells. Receptors. These are things that are going to be these proteins on the surface of the cell, right? These drugs are going to dock in there, these ligands, and then they're going to change the way these receptors work. Not a big deal. We either want to enhance or reduce normal functioning of the cell. That's what neuropharmacology, psychopharmacology is going to do. It's going to affect the activity of neurons up or down, right? So if you need to inactivate some cells, hey, we'll do that. If you need to activate some cells, we'll try to do that as well. Most of these drugs will not actually get into the neurons, okay? What they will do is they'll just interact with the receptors on the surface, right? Just like the neurotransmitters. Here you go. Here's a great, complicated, detailed drawing. It's very simple. It's just a triangle going into a triangle hole. Very, very complicated. I assure you drugs are not shaped like triangles, okay? They're very complicated shapes. And the receptors are very complicated shapes, right? So we're going to fit that in there, quite easily, and then we're going to have some effect on the inside. It's a very straightforward. Now, there are some exceptions to this. One of these is going to be like steroid hormones. You've got some of these in your body. You may decide to take some of these for some reason or another. Those guys, because of their structure, are going to be able to pass through the cell membrane quite easily. They'll actually get in, activate some internal receptors that are then going to alter DNA transcription and eventually protein synthesis, right? And so you'll kind of upregulate or downregulate protein synthesis using steroid hormones. So that's kind of the exception to the it always stays on the surface of the cell story. And these are going to be like hormones. Again, they'll actually get into the cytoplasm or the nucleus and change that gene expression. Not a big deal. Hey, look at this word. Who said that before? I did. So affinity, here it is. Again, we want to think about that. This time we're thinking about agonists or antagonists. This can get complicated, but ultimately you got to ask yourself one question. Is this increasing or is it decreasing activity? That's it, right? And of that particular substance. If it's an agonist, right, it's going to act like the substance that it's, it's going to mimic a substance or mimic the effect of a substance, enhance that effect, whatever that is. If it's an antagonist, it's going to reduce that effect, right? So either way you go, that's what you want to think about. Now, agonist and antagonist, we could talk about this. They can attack a lot of places. Here we're just thinking about receptors, right? But they can actually work upstream from the receptor. They can alter dopamine release, for example. Cocaine will do that. But they can play a role in the synthesis of neurotransmitters. Doesn't have to be right at the receptor, okay? So there are drugs you could take maybe, if you really wanted to get fancy, that could destroy vesicles, So you can't release as much acetylcholine, for example, if you want to, like, I don't know, paralyze somebody. So, you know, you never know. You never know when you're going to need this. So that's a fun thing to think about. All right, here are some other great complicated things. So the idea here is if it's an agonist, it's going to fit the receptor, and it's going to be able to activate sort of that active site, right? And it's going to cause some downstream effect. If it's an antagonist, it'll still fit in the hole, but it's not going to do anything. It'll just fit in there and prevent anything else from binding into it, right? So the actual neurotransmitter or the agonist is not going to be able to bind. You're just occupying it with like an empty spot, right? So there you go. It's kind of like an empty shoebox in your closet. Anybody have empty shoeboxes in their closet? Yeah, some people do. But they're all the ones sitting in the back row. That tells you something about it. So if you've got an empty shoebox, what's it doing for you? It's not doing anything, right? It's an antagonist because it's keeping you from putting other shoes in there, right? If you were to get rid of that empty box, you could fit another pair of shoes, which would be nice because then that would be like the top here. Sometimes you have to keep the shoebox for a while to make sure the shoes don't break, right? Do you ever do that? That's what I do. But maybe
Christmas, what shoes are you buying?
all kinds, and they break. So you never know. I buy expensive shoes because they break, and I try to buy nice ones that don't break. Partial agonist. Hey, this is actually kind of cool. Now we give people medications a lot that are partial agonist, partial antagonist, agonist-antagonist combos. You've got your inverse agonist. The reason we do this is, well, there's an easy example of Parkinson's disease and schizophrenia, right? So if you have schizophrenia, what are we going to do? We're going to give you a dopamine antagonist, right? You've got too much dopamine in your system and we need to shut that down. The problem is that's going to give you Parkinson's disease. And most people don't want that. I mean, that's like, people aren't signing up to get Parkinson's disease, right? And so it's called tardive dyskinesia is like the technical term, right? If you're dealing with it with a drug-induced situation. So we know, okay, we don't want to do that. The flip side of that is if you have Parkinson's disease, it's because you don't have enough dopamine. So we'll give you a dopamine agonist so you have more dopamine. The problem is then you start hearing voices, which is also not what we want to happen. So there's this fine line between treating and not treating, right? And so what you might try to do, because we're not quite good enough yet, but we're getting there, not quite good enough to go, well, we only want to increase or decrease dopamine in one particular part of your brain. That would really be great, right? We're almost there, but not quite. So what you might do is give someone a partial agonist, partial antagonist, something that's going to have an intermediate effect, right? It's going to work a little better than nothing, but not quite as good as the full, dump of dopamine, right? And that would be enough to maybe alleviate someone's Parkinson's symptoms, but not enough to give them, for example, so they start hearing voices, right? So you want to kind of avoid that. So that's sort of where we are on this now. Works for a lot of other things as well. Parkinson's and schizophrenia are sort of the easy, best examples there.
Where does like an ER medication, does that fit into this at all?
An ER medication?
Like extended release?
Oh, you can use an extended release for a lot of things. You still want to be careful, right? Because you don't want to have like an extended release of something that's going to be just jacking up your dopamine levels forever too high, or dropping them down too low. But you could use them for, just sort of anything. I think that's better for folks. That goes back to the idea about the half-lives and how often you want to take the medication to change that concentration, right? If you have something that's extended release, right, and let's say that that half-life wasn't right around that 8-hour mark, but if you could do an extended release version of that, you might be able to change the dosing frequency so you can maintain that steady state concentration.
ADHD medication.
Yeah, that's a good example, right? A lot of ADHD medications are extended release for that reason. So there you go. Fun stuff, right? Other questions? That was a pretty good question. Here's kind of a nice breakdown of all that stuff I just told you, in case that didn't make sense to you. Again, we said drugs can work in a variety of ways. They'll just have to work on the receptor. Not a big deal. That ligand receptor binding is temporary. At some point, the receptor is going to let go, right? So this is a really sort of important concept to keep in mind. These are all like statistical probabilities, right? So you didn't think you were going to get that in this class. What I like to tell people is like everything that ever will happen in your body is happening right now. It just may not be happening at a rate that makes a difference to you, right? Because it's all statistical probabilities, right? Like whether or not these receptors are going to bind, but the ligands are going to bind to the receptor or not, how long they're going to bind, some are going to just release quickly, some are going to stay bound for a longer period of time. It's all these like time constants of things, right? And you don't really need to think too much about that. All you need to know is at a certain point, the ligand's going to just float free of that receptor. It could bind somewhere again, right? That's a possibility. So it could bind again after it's been released. Could once it's released, that inactivation step could come in. We could break down that receptor or that ligand. We could sweep it up. Whatever could happen there, but it's not a permanent binding, which is great. If you think about that, if it was permanent, you would take a drug once, that receptor would be stuck with that ligand the rest of your life, and that ion channel might be open or closed or whatever, right? And then you're just stuck that way forever. Which,
Dosage right.
huh? You better get the dosage right. Yeah, you don't want to play around with that, right? It's got to be right on it. So that's a great thing. We should take advantage of. Affinity plays a major role, Cassie, in how long that ligand will stay bound to that receptor. The higher the affinity, the longer it'll stay bound. The lower the affinity, the more quickly it'll be released. So there you go.
Is that why like synthetics are more dangerous sometimes?
Yeah. Synthetics have that high affinity and they're dangerous. And when they're bound, they'll stay bound for a while. They'll have a more powerful, longer lasting effect, right? We've designed them that way intentionally, right? Now their abuse potential goes up, right? And that's why synthetic opioids are much more likely to be abused than naturally occurring opioids. That abuse potential, not that the abuse potential is low, for those like opium, right? That's not going to do anything to you. Have at it. Nobody's ever been addicted to that. So there you go. We talked a little bit about upregulation and downregulation. This is just changes in the number of receptors that are available, right? This can happen. This is kind of that tolerance mechanism, Cassie, you were asking about earlier. This is one of them, not just enzymes, but with the receptors. If you have chronic activation of receptors, you're going to downregulate. You want to stay at that homeostatic level, right? You don't want to go up or down too much. If you're constantly taking a drug that's jacking things up, you're going to pull back those receptors. Okay? This is one reason, like for Parkinson's disease, L-DOPA works for a time, right? And what happens over time, you have to increase L-DOPA, which is a precursor to dopamine. So you have to increase the amount of L-DOPA you're giving these individuals because they're pulling back what receptors they have. They're pulling, right, because you're having this chronic activation. And once you get to a certain level and the L-DOPA levels are so high, then you've got to worry about like giving them voices in their heads, right? So that's why you run into these problems. There are all kinds of subtypes of receptors. I'm not going to expect you to understand that or understand too much about it, but know they exist. The thing about subtypes, and this becomes really important when we'll talk about opioids, there are, the mu, the kappa, right? There are different receptors, and these receptors have different effects, right? So some of them might have the analgesic effect, some of them might have the you're not breathing anymore effect, right? If you take enough morphine, you'll stop breathing. I don't know if you guys knew that. Just watch out, for that. So understanding these subtypes and being able to activate or inactivate subtypes, develop drugs that only work on a particular subtype is great because then we'll have a better understanding and a better way to treat particular disorders and possibly eliminate side effects. I don't know. You don't really need to know about that. Dose response curves. Some important things to think about. We've got what's called ED50. This is the effective dose for 50%, right? So you want that like half maximal effect. Not a big deal. you want to calculate, you know, like what's your maximum response, what's your sort of effective response, you know, and you can kind of plot these curves, right? It's a dose response curve. You give people more drug, you get a bigger effect. Not a big deal. At some point, you're going to plateau, right? No matter how much more drug you take, you're not going to get more of an effect, right? Caffeine is like this, right? So at a certain point, doesn't matter how much more coffee you drink, you're not going to get more hyper, right? You're right there, and that's all you're getting. So that's going to have that. Methamphetamine does the same thing. The maximal effect's a little higher than caffeine, but there's still a plateau, right? It's still going to plateau when you get up there. There's a certain maximal effect, no matter how much more drug you give somebody. All right. When we talk about potency, we're talking about how much drug do we need to give somebody to get an effect. We want to compare different drugs, compare their potency. So if we want to compare methamphetamine and caffeine, for example, right, we can do that pretty easily. How much of this drug do we need to give you to get this effect? If we need to give you less of that drug, then that's a more potent drug. Here you go. Here's an idea about pain threshold. You know, here are a couple different pain medications. Here's the amount of drug we have to give that person to get, you know, like an effective dose. And you can kind of see that some drugs you have to give them less. You have to be careful with those drugs, right? If we give you less of that, we're dealing with a small margin there probably, right? Between how much of this drug we can give you to solve your pain and how much of it we give you to kill you, right? If you have to take this much drug to alleviate your pain, I mean, how much more maybe do you have to take to kill you, right? It's quite a bit. That's why I tell people, like, if you're going to do a drug, always do LSD. And the reason for this is a lot of reasons. There are a lot of great reasons to do LSD over other drugs, I should say, right? Not just like in general you should do LSD. Probably shouldn't advocate for that. It's a relatively safe drug, right? You can take like a 20,000 times higher dose of LSD than what you need to actually like have a trip, and it won't kill you. I don't see too many people taking 20,000 times more cocaine than necessary and then not like exploding, right? Because that will happen. Carmen, are you okay?
Yes.
Okay. Just checking on you. You seem, I don't know, you're thinking about cocaine users exploding. Which could happen. I think with LSD, the bigger concern is like what you think you're doing while you're on LSD, right? And how that actually interplays with the real world, right? Okay, so that's an important thing to watch out for. Like, if you think, well, like I can fly, and you can't, and you're like upstairs somewhere, that can cause a problem. If you're downstairs, it's not so bad, right? So you're okay. So always do LSD on the ground floor. That's important. But again, there's a very wide margin of error there with LSD that you don't have with other drugs, right? It's the aspirin of illicit drugs. So we're thinking about now toxic dose, right? So we want to compare, we want to make a therapeutic index, we want to compare the toxic dose and the effective dose. It's pretty easy to do, right? So here you go. If we're thinking about you know, sedative effects of something, and then respiratory depression. So that's going to be the effective dose, and there's going to be the toxic dose. That's a pretty wide margin of safety. That's not so bad. If you think about that, if, for example, respiratory depression was like right here, you know, and you were looking at that sort of in this space, then you would think, well, that's a much narrower therapeutic index, and you have to be very careful because you may kill someone, right? You want a wide margin of safety there if you can. All right, we're still up 20 minutes. Who wants to stay later? Nobody's going to say yes. Nobody said no. I don't know why. Like, you all should have said no. Why didn't you say that?
No.
No. Great job. There are competitive antagonists. Sometimes these antagonists will compete with agonists to bind. So that works, right? They can be replaced. if you have more of the agonist, right? Naloxone is actually a great example here. It's a competitive antagonist of morphine. Okay? So if someone has overdosed on an opioid, and you can give them naloxone, right? So that works. Why does that work? Magic? No. We're thinking about affinity again, right? We're thinking about this competitive antagonist. Naloxone is shaped like morphine. So it will bind to that morphine site, but it won't do anything once it's in there. It just occupies it, right? Morphine can't come in and do anything, and then naloxone's not going to do anything, right? It's in there, nothing else can come in, right? And so it can take the space of that morphine. So when the morphine lets go, the morphine won't rebind to those sites, right? And then you can, prevent the overdose effects there. That's exciting, right? How many of you carry naloxone with you? Anybody? Yeah, I knew some of you did. 2 people? That's great. We appreciate you all looking out for everyone else in this city. Just a little guilt trip. Doesn't work. You guys don't care. Cold-hearted. That's fine. No, I understand. I don't carry it. Whatever. There you go. Talk about response latency, not a big deal. Non-competitive agonists, these are a different story. These will actually bind to the sites. They can bind somewhere other than the agonist binding site. Okay? So these guys are cool. They're not competing for the same location, right? So Jessica, they're not going in there where the morphine is. They're going in somewhere else. The morphine can stay there. We don't care. This non-competitive agonist will go over there, and it'll latch on somewhere else. So you don't have to wait on that first ligand to let go and leave. You just go and bind somewhere else. And then you can shut down the effect of the agonist. So that's pretty exciting, right? So 2 drugs can work in opposite directions. That's not a big deal, right? We kind of understand that. They can also have additive effects if they work in the same direction on something, right? So a lot of times, if somebody's coming in because they're depressed, how many medications are they going to have for that? Like 3, right? Because they're going to take drug A, and they're going to take drug B that helps drug A, right? And then they might take drug C that helps drug B, which will then help drug A, right? And then you kind of like add these things together, like Abilify, right? Why do you take Abilify? Because whatever you were taking wasn't good enough and it needed a boost. So you're taking like something else on top of it, right? Does that work?
Benzos and alcohol?
Yeah, that's it right there. The alcohol's not making you sleepy enough. Always add the benzo there. Those work for you. Sometimes they'll have potentiation. So you can take the 2 drugs, and they'll actually give you a greater effect than the 2 of them put together. That's not a big deal. Not a big deal. You understand all of that. Tolerance, we talked about this briefly. We've talked about how that might work. There is cross-tolerance. This happens. Why would cross-tolerance happen?
Tolerance to one drug can diminish effectiveness.
That's what it is. That's not why it happens. Remember those CYP450 enzymes we talked about, right? So if one of those enzymes is responsible for breaking down multiple drugs, and you've induced the production of that particular enzyme, then the second drug you take that's in that same family, right, you're going to have tolerance to that. Sometimes they're shaped similarly, right? And so you might have affected other receptors as well, right? So it's a lot of it's about structure and shape. Okay, so if you think about that. How many of you have ever met someone and you didn't like them because they looked like someone you knew who was horrible? That's cross-tolerance. Right? Kyle's thinking about who is that person. It happens, right? It happens all the time. You guys admitted to it quite easily. There are things called acute tolerance. You can develop this after like 1 time, right? Not a big deal. Metabolic tolerance, this is when we're thinking about enzymes, right? We've talked about that a little bit. Pharmacodynamic, what are we thinking about here? That's receptor upregulation and downregulation, or it's a particular type of tolerance. Not a big deal. Part of the problem is like withdrawal, right? So once you've taken a drug for a while and you've developed that tolerance and you're like, man, I'm done with this, and you stop, guess what? You feel horrible, right? That's why so many people go back, right, to taking drugs. Because why were you taking the drug in the first place? To feel better, right? And then you stop taking the drug and you feel worse. You're like, oh, this is bad. I'm going to take the drug again, right? It's a long process sometimes to go through that withdrawal because you have to undo all of that work you did developing that tolerance, right? It's these compensatory mechanisms and these changes, right? So you spent all that time jacking up those enzymes, down-regulating those receptors, and then all of a sudden you're removing that extra agonist, right? That was actually causing you to operate at a normal level, so now you're operating at a lower level. And you feel bad. And you've got to wait on those enzyme levels to come back to normal. You've got to wait on those receptors to come back to normal, right? That can be a very long and a very difficult process, right? Sometimes it can even be a very dangerous process, right? This is like, it's kind of weird. Like if somebody comes in and you're working at a facility that deals with drug and alcohol abuse, and somebody comes in, they're an alcoholic, and they say, hey, I'm ready to quit. And you say, no, I don't think so. You need to keep drinking for a while, right? Because you don't just cut them loose. You don't just do that, right? Because they can actually die from this, and that's a thing to think about. You say, no, you should probably just keep drinking, right? So you kind of feel weird for a moment, I would assume. I don't know, right? I'd be like, here's a 12-pack, go home. Come back tomorrow. We'll see how you do. So you got to watch that, right? So it's these really sort of difficult things. Withdrawal or abstinence syndrome, it's sort of the same thing, right? If you think about it, most people talk about it as withdrawal. We use abstinence syndrome when we're talking about like kids mostly, right? People who are born addicted to something. And, I don't know, there's like some different connotation there, right, to the word like abstinence syndrome. Wasn't your fault. You were on heroin, so we're not going to call it withdrawal. It's the same mechanism, right? It's the same biological mechanism. You can put whatever word you want on it. This is kind of interesting. We won't talk a whole lot about behavioral tolerance. We will some. It's related to like context-specific stuff. It's kind of cool. You guys know about classical conditioning, right? Okay, I won't work too much on that. You know, it's a lot about like seeing paraphernalia, and you can still have those sort of effects. Not a big deal. We're not going to worry too much about hypothermia. Not today, at least. Operant conditioning, you know, it's about state-dependent learning. That's kind of an interesting concept. I won't spend a whole lot of time on that, but you know, these are like, I wouldn't recommend this, like studying this class while you're drinking. You would want to take the exam while you're drinking, right? So you could sort of perform better on that. Just like state-dependent learning. That's why you should do all your studying sober. Just as a heads up. Sensitization is sort of interesting. It's the flip side of tolerance. Maybe we should talk about this a moment. If you keep taking the same dose of something over time, you actually, some of the drug effects are enhanced. Typically, we're thinking about like side effects with this. We're not usually thinking about the desired effects here. We usually think about side effects there. Pharmacogenetics, I don't know if you want to think about that. But that's kind of interesting. We're thinking about genetic factors. Probably won't focus a whole lot on that. Unfortunately, we're not quite as good on this as we should be, right? So we'll get better. We've talked a lot about these CYP450 enzymes. Again, if you know someone can or cannot break down a particular drug or drug class, then you can adjust their medication or change the class completely, right? And this also works with folks. There are some folks who have different kinds of like serotonin receptors, right? And so you can actually do genetic profiles on individuals to see what sort of serotonin receptor activity they have, if that's up or down, and then you can figure out if an SSRI is even going to work for them, right? Some people have like really crummy serotonin receptors, so you might go like, SSRIs are going to be a waste of my time, right? I don't have enough serotonin receptors to even try to help them out. Let's try something else that might work. And so those are things to keep in mind as well. So if you keep trying different kinds of SSRIs with someone, you're like, well, that's not working, maybe switch to a different class of drug. They may or may not have, you know, the genetic makeup for that to work. Polymorphisms, we talked about all of that. Routine genetic screening, again, it's going to be important, but people aren't doing it. It's costly. A lot of insurance companies, right, won't cover it. I don't know if you guys know about insurance or not at this point in your life. Right? You should, right? I mean, that's the thing, like, to keep in mind. I don't know. A lot of folks don't really get the, like, how insurance works very early in their lives, right? But you guys might, because you have to deal with insurance providers and stuff, right? So that's going to be important. Anybody have any questions? I know that was like a lot of information, right?